Radiation oncologists talk about this thing called fractionation. What does that really mean? Well, we learned a long time ago if we gave this much energy, we could actually impact cancer. And how we broke it up was built on radiating pigs and seeing if their skin got a sunburn, right? I mean, that was the fundamental basis of radiation. It doesn't seem like that's the greatest way to build a plan, but that's how the whole field was built out. And then there was a whole bunch of advanced mathematical radiobiology that followed, talking about what we call the alpha-beta ratios. And the conventional wisdom is that the alpha-beta ratio is about 10. And that's how we created 9 weeks of radiation therapy. But the truth is, we kind of made it up, right? We made it up based on mathematical modeling, and then all of a sudden we said, what if we were wrong? What if we were wrong about the math, and the alpha-beta ratio wasn't the number we said, it was a different number? It would mean that actually giving fewer fractions of radiation therapy may have some importance. Indeed, fewer fractions of a higher daily dose could theoretically have better or same cancer control, fewer complications, greater convenience, better patient acceptance, and, as everybody always cares about in society, lower cost. And this would have ramifications for both external beam, brachytherapy, other kinds of technology that you think about. So, a lot of people have thought about this over the last 2 decades. And finally, in 2018, there was a manuscript that came out within the last month or two, not in one journal, not in 2 journals, but in all 3 journals that represent the oncology field for this area. In AUAs, in Astros, in Acro. And they're relevant in JCO, in practical radiation oncology, in JCO. So what we're looking at here is really a guideline that is permeating through all of the different specialties. So let's see if we can now spend the next 10 minutes and really hone down to what it means for you here in the audience. So hypofractionation means going faster. This recommendation applies to external beam radiation therapy for patients who require or prefer treatment instead of surveillance and have opted for external beam instead of a radical prostatectomy or other treatments for localized prostate cancer. This was the data set of which the guidelines were built, right? So it's really small. I'm not asking you to try to really see or look at each individual study here. But my point is, how many patients have we treated with prostate cancer in the universe? Like every man gets prostate cancer, right? And half of them maybe get radiation and half of them maybe get surgery. When you look at the sheer number of patients on these trials, it's this slide and that slide. That's it. So we're building our recommendations on a lot smaller population than we have done in the world for 9 weeks of radiation therapy. That's not to say that this data isn't fantastic, but we have to, right, whenever we do something new, there'll always be less data than the cumulative 6 decades of radiation therapy, which has helped our patients with prostate cancer, right? So let's go and see what the guidelines recommend. The key recommendations are as follows. For men who've opted for external beam, we first called this thing called moderate hypofractionation. So how many of you would say you know what the words moderate hypofractionation are? Well, it means a fraction size of about 240 to 340 centigrade. Now that's different from what we currently do. Do you guys know how much we usually give? It's on the slide. It's 180 to 200 centigrade. So you figure it's up just a little bit from 180 to 200 to 240 to 340. And that in the recommendation says it should be offered as an alternative to conventional fractionation. And that was regardless of cancer risk group, regardless of patient age, regardless of comorbidity, regardless of anatomy, and regardless of baseline urinary function. Whoa, right? So we're saying that it's okay to increase the fractional dose to 240 to 340. So what's the regimen you're going to use? Well, the standard board answer when I teach the pups what to say when they're trying to get ready for their boards was a number like 79.2 gray and 180 centigrade fractions. So when you put that in your mind, now we're talking about the suggested regimens for moderate hypofractions include these two schedules, of which the largest number of patients were seen in the randomized clinical trials. It's either 6,000 centigrade delivered in 20 times of 300 over 4 weeks, or 7,000 centigrade delivered in 28 fractions delivered in 250 centigrade per fraction, which turns out to like 5 to 6 weeks, right? 5.5 weeks. When we look at the fractionation and dose constraints of moderate hypofractionation, here we see the different trials. And so what I would show you is, right, I said that when you interrogate the data, there wasn't as many trials as the universe as we've treated prostate cancer patients, right? And even within this, very few did the same amount of dose. So the data really is limited compared to breast cancer, where there were 6 large prospective trials that caused that change from doing mastectomies to doing breast conservation therapy. Now, while moderately hypofractionated external beam confirms similar cancer control and side effects to conventional fractionation, there were some things that jumped out. So when you say, oh, we're just going to go faster, well, physicians need to counsel patients about a small increased risk of short-term GI toxicity. What does GI toxicity sound like? Rectal toxicity. And that has implications to the talk that you just heard. Additionally, getting back to Raul's interesting points, when we discuss going faster, you have to have a conversation how the data is limited for the oncologic outcomes beyond 5 years post-therapy, because we don't really have good data with that. And here I've come back to show you again the slides. There's a small increased risk of GI toxicity that's associated with going faster. Now, the data that we are looking at is looking shortly thereafter radiation therapy. Nobody's looked 30 years down the line here. So we honestly don't know what it really, really means to go faster with long-term, what we call late toxicities. The second part of this talk is about these words called ultrahypofractionation. Isn't that sexy? Which is more sexy, ultrahypofractionation or stereotactic body radiation therapy or SABR or whatever you want to call it? But this applies to just going faster. And when you go faster, you're going at dose rates, at doses that are equal or greater than 500 centigrade per treatment. All right, so I want you to separate in your minds. We got moderate hypofractionations, which is just a little bit higher, and then what we would call stereotactic doses. So I've been interested in this in a long time. I had a fortune to write a seminal manuscript in practical radiation oncology with Pat Capellian several years ago, arguing on the pro side, this is point counterpoint, on the pro side that this is both rational and reasonable to go faster. Because really, let's think about it. You're in a room with a patient, like we all are, and the patient says, I want radiation therapy, but I don't really want to see you, right? I want to be done. And Pat Capellian said it best when at Astro he gave discussing on the data that Robert Lee presented on moderate hypofractionation. And he said, hey, we can go faster with moderate hypofractionation, but who cares? Does it really matter if you go 6 weeks or you go 9 weeks? Does the patient really care that much? What patients really care about is going in 5 days, right? Can I just come in 5 days and be done? And so ultimately, we're really most interested, I think, as a society, maybe not as radiation oncologists, but as a society about ultra-hypofractionation. Now, when you look at the data for this is the studies that were done. And this shows studies of outcomes with early stage prostate cancer treated with SBRT. And the minimum follow-up is 4 years. So when I used to give this lecture for David, I would have as a CME question, I would say, what was the group that we have the most data with? And it would be low-risk prostate cancer. If you're willing to do active surveillance, we were willing to try something like stereotactic. So we don't have tremendous data as it goes to worse risk groups, i.e. high-risk prostate cancer. When you look at the toxicity quality of life data from one of the key presentations, again, we see this increase in GI toxicity. And also, there's probably a slight increase in urinary toxicity that may go along with it. So when the guidelines were created, they stratified this time by low, intermediate, and high. Remember I said for moderate hypofraction, it was agnostic regard to your cancer risk group, your age, etc. But for ultra hypofractionation, now we're going to talk about by individual risk group. That make sense? All right, for low risk prostate cancer, for patients who have opted for radiation therapy, this may be offered as an alternative to conventional fractionation. For intermediate risk, it may be offered, but the expert panel strongly encouraged treating these patients as part of a clinical trial or a multi-institutional registry. So what we're saying really is we don't have the most robust data, and we still need to probably collect it in an organized fashion. And then for high risk, the panel did not suggest, let's say that again, did not suggest offering ultra-hypofractionation outside of a trial or registry. And the recommendations for ultra-hypofractionation were graded by the panel as what we call conditional, reflecting the limited base of current evidence. So, okay, I'm going to give ultra-hypofractionation. What am I going to do, right? So, again, when you go back to the slide I showed, they were all over the place with respect to dosing, not a uniform dosing, but the most commonly used schedules in the trials were 3,500 centigrade in 5 fractions, which comes out to 700 a pop, or 3625 centigrade in 5 fractions, which comes out to 725 a pop. So when you look at the large-scale randomized trials that are coming down the pike, right? So look at the words over here in current status. The words are currently accruing. You can see that the common thread in this seems to be 3625, but again, we just don't have a common fractionation or significant amounts of data in the higher risk patients. For 5 fraction regimens, the expert panel recommends against total radiation doses larger than 3625, as we just did not have experience outside of the clinical trials that I showed you. The other thing is when you do 5 fractions, people think, I'm going to do 5 fractions Monday through Friday and be done. That's probably what you shouldn't do. Stereotactic approaches is defined by 5 fractions delivered within 2 weeks. And so consecutive days should also probably be avoided. So you're doing something that sounds like Monday, Wednesday, Friday, Monday, Wednesday, or something that Tuesday, Thursdays, but you shouldn't put 5 in a row. The recommendations also address the technical aspects of planning and delivering hypofractionation, which includes what you're aiming at, the target, what the normal tissues, the dose constraints, how big you make the margins. And this is something like doing a prostatectomy, right? You just don't walk up and you do your first prostatectomy. You actually have to learn the techniques of how to do this, because for the first time, you do 9 weeks of radiation and you miss the target, and you do it over 45 treatments, there's a fudge factor, right? You do it in 5 days, you better be good at hitting the target. And indeed, the expert panel universally recommends image-guided radiation, so you actually visualize the target you're aiming at, and avoidance of non-modulated conformal techniques. Again, fractions size between 340 and 500 have been examined in very few studies and were outside the scope of these guidelines. And also that was excluded from the current guidelines is treatment of locally advanced metastatic disease, postoperative disease, salvage therapy, and re-irradiation. Is this interesting? It's extremely obviously interesting to go faster. For me, for those who know me, I sort of cut my teeth with the surgery branch under Steve Rosenberg, and why I'm a radiation oncologist is because when you deliver radiation therapy, besides the double-stranded DNA breaks, there's probably really interesting things that happen with the immune system. This was the most published manuscript in 2011 with Bob Timmerman and my gold-winning friend, Bill McBride. This set the stage that radiation and immunotherapy may have some synergistic things, which we are still working hard as next generations in radiation therapy. And with that, I think if you learn anything in 2018 about what's happening in radiation for prostate cancer, it has to do about what is the field going to do in reaction to the guidelines I just showed you.